So our next topic is Inspired and the Upstream program in hospital and community-based COPD programs. Jenn Rooney has been a respiratory therapist for 25 years. She has worked clinically for the first 13 years of her career with experience in the operating room, critical care, and pulmonary functions. She was the education coordinator briefly before she became the clinical coordinator in 2012. Naida Keetch, her co-presenter, works part-time at St. Joe's Community Health Center, providing Upstream, and part-time at the St. John Regional Hospital doing Inspired. I also know that she works in a lot of other places too, so you must have speedy transportation to get back and forth to all the places you work. She provides spirometry, COPD, and asthma education to rostered patients, as well as patients that live near the centers based on postal code. So welcome.
Hi, thank you very much for having us. I also wanted to note that with Naida working in both the hospital setting and the community setting, it's a huge asset. And she's done a great job at helping to implement these programs and integrate these into her practices. So today we're just going to talk a little bit about little history on the programs and tell you where we are now.
Did you want to turn your camera on?
We don't have one, I'm sorry.
Oh, that's okay? That's okay. I'll just tell him
that yesterday. Okay, and we were nervous, so it's better. So, COPD in New Brunswick. COPD has been the leading cause of respiratory failure and has considerable impact on patients, families, and the healthcare system. The most recent data shows that 1 in 9 New Brunswickers over the age of 35 have been diagnosed with COPD. And after the age of 65, that number increases to 1 in 5. However, in those statistics, it does not include the people that have undiagnosed COPD. It's estimated that there's approximately 27,000 people living in New Brunswick with undiagnosed COPD. The concern with that is that the lack of diagnosis means that these individuals do not have access to appropriate and timely interventions, and this could impact their quality of life. Many of those with undiagnosed COPD also attribute their early symptoms to normal aging. They think they're out of shape, that's why they're short of breath, or they know they are a smoker, so these are just the normal symptoms of smoking. So how do we help our patients with COPD? And we help them by trying to achieve some of these goals. So we want them to have better understanding of their disease. We want them to have an improved quality of life, some autonomy, reduce their exacerbations and need for hospitalization, have access to action plans, advanced care planning discussions, drug and device optimization education, and if possible, access to pulmonary rehab. So to achieve these goals, a doctor in Nova Scotia, his name was Dr. Graham Rocker, developed a program to help patients with chronic respiratory disease. And the goal of this program was for patients to be educated on their disease and have access to tools that would prevent them from having to go to the emergency rooms or from being admitted into the hospital. So he called this program Inspired. And the acronym for this is Implementing a Novel and Supportive Program of Individualized Care for Patients and Families Living with Respiratory Disease. So a little program overview for Horizon. So it is an evidence-based, it's very supportive, and it allows them to self-manage for the patients and for their family members for patients with moderate to severe COPD. We implemented Inspired at the St. John Regional in 2015 for admitted inpatients. And then over the next couple of years, we fully implemented in all Horizon hospitals except for Sackville and Grand Manan. However, this year, we were lucky to have a full-time position for a respiratory therapist in the Grand Manan Hospital. She started in July of this year. So we're hoping to implement Inspired in Grand Manan next year. So after the implementation of Inspired, Horizons saw the benefit of the Inspired program for inpatients, and they recognized the need for this type of programming for outpatients as well. And they developed what we call Upstream. So Upstream, again, was developed based on Inspired, and it's for patients in the community, outpatients. It was implemented in 2018 at various community health centers across Horizon. And from 2018 to 2022, 628 patients have been enrolled in Upstream. And this year, it was recognized by Accreditation Canada for leading practice. So who's on the team for Inspired and Upstream? So in the hospital, there's hospital-based RT COPD educators. In any program when we implement, we always want to have a physician champion. We have our attending physicians, pharmacists, our patient flow coordinators and discharge planning, our social workers and spiritual care. And they are all readily available to these patients if they need their assistance. Then in the community, we have our community-based COPD educators. We have our physicians, nurse practitioners, community health centers, our extramural respiratory therapists, and our community pharmacists. So the next process is, how do we select our patients? How do we know when there is a potential COPD patient admitted into the hospitals for Inspired? So every site has different barriers and different processes in flagging our COPD admissions. And some patients who are admitted, they're admitted for other reasons, but they still have COPD and could still benefit from enrollment into Inspired. So because there is no common electronic medical record shared between the zones, one initiative that we did was to create a spirometry database. So and that was done all manually. The database has been very helpful, but it does have some faults as it depends on the frontline staff to update it. Then we tried to find different ways on admission to help screen these patients. So for example, at the St. John Regional Hospital, when patients are admitted and answer yes to having COPD, they are flagged for the Inspire program and are seen by one of our respiratory therapists. The other way that patient selection occurs is by a healthcare provider referral. So this can be anybody within the circle of care of the patient. So it might be the pharmacist, the nurse, or the attending physician, and they would put in a referral, and they would, again, be seen by the respiratory therapist. For Upstream, it's a little bit simpler. The patients are referred by their primary care providers. However, the primary care provider must be affiliated with a community center offering the Upstream service. So when the patients have been flagged through our screening processes, before we even go to see a patient, they must have a confirmed diagnosis of COPD by spirometry, and they must be aware of their diagnosis. Some patients you go and you see them, they have a spirometry and you're like, oh, they have COPD. But when you start questioning them, they aren't aware of that. So until they're aware, we do not continue with our consult. If the patients meet the criteria, then we do an initial consult with the patient and a smoking cessation consult if needed. So if they meet the inclusion criteria, we still have to meet the patients to see if they meet our full enrollment criteria. So this is just a framework for the two programs to show. So of course, Inspired was inpatient, Upstream outpatient. Both must have a confirmed diagnosis by spirometry. And spirometry is the gold standard tool used for diagnosing COPD. In both programs, you must have a primary care provider. And again, in Upstream, they must be affiliated with the community health center. So this is important, the ability to self-manage. So patients must be able to understand and self-manage their action plans, or they can have a family member that can help them. When we look at patient location, both sets of patients must be community dwelling. So at this time, we do not have a process It might be coming in the future, but we do not have a process for nursing homes or people in special care homes. How are they supported once they're discharged? For Inspired, we have the extramural program, who are great. They follow the patients for up to 6 months once they're discharged, and they may keep them on longer if needed. And there are other community partners that may also go in and follow up with these patients. With Upstream, the follow-up is through 811. So 811 is the telecare service, and they provide 24/7 support, which is great. When the patients are enrolled and have their action plan, the action plans are sent to 811 so that they have them on hand. And they also get support from the community health centers. So now we're going to talk about the components, and I'm going to let Naida discuss this, the components of the program.
So there are 3 main components of both programs, and these are education, and with that we use the Living Well with COPD, medication optimization, as well as action plans. So for education, we use Living Well with COPD. This booklet is used at all sites and with both programs. It's used to educate the patient as well as their families on their disease and strategies to better manage their breathlessness. There's a few chapters in the book. There's information about triggers for their exacerbation. We teach them about pursed lip breathing, stress management, because anxiety and stress are a big component of COPD, body positioning, ways they can move their body so that they can breathe more comfortably, coughing techniques, healthy living, and physical activity, because studies have shown if they can exercise and keep moving, then it will improve quality of life, and that's why we try to push for pulmonary rehab programs as well. The second component is medications and optimizations. There's a lot of factors to consider when we're choosing which medications for patients. Do they have drug coverage? What have they been on in the past? Allergies, contraindications? Do these drug devices and drugs suit the patient's current conditions and disease severity and lifestyle? For example, do they have an adequate inspiratory flow rate to properly deposit the medication into the lungs? Do they have hand coordination or strength to use the device? Inhaler technique needs to be assessed regularly, and education is provided. And the last component is the action plan. This is the part where we need the physician buy-in and to get the prescriptions. Our goal is to get antibiotics and oral steroids to have on hold. Patients and their family are trained when they should take an antibiotic. When they notice there's a change in their sputum, they would have these on hold. These antibiotics would have a prescription for a year, and patients and families are encouraged to have these renewed yearly. If they're having increased shortness of breath, then they're instructed to use their blue puffer, their rescue one, and if after 48 hours this doesn't work, then there's also prednisone on hold. If something happens that we can't get the action plan with prednisone and antibiotics, then the patients are taught when to start their blue puffer and to instructed to call their primary care provider as their symptoms are escalating and will need further assistance.
So once the patients are discharged or after they've been enrolled in the program, we do continue follow-up with them, like I said, with EMP for our Inspired patients. It's usually up to 6 months. And for the Upstream,
You could see them yearly.
okay, so when they come for follow-up or when they're seen, we do continued education. And again, we review their Living Well with COPD. We reinforce the action plan, make sure that they understand it. Do they have any questions? Enrollment in pulmonary rehab where available. We do ongoing smoking cessation counseling if needed. Advanced care planning discussions. We continue patient assessments, and then we communicate the patient progress to their primary care provider. So after the program was up and running, we did look for feedback from patients. And as you can imagine, it was very good. Patients reported 88% satisfaction, and they reported the goal of the program. They had were more confident in self-management of their disease. They were appreciative of knowing how to use their medication effectively and understand their dosing. And then they were also made aware to not delay medical treatment with onset worsening of symptoms, because as we know, the sooner they catch the symptoms and treat them, it decreases their exacerbations. So some data from 2017 to 2020, and you'll notice it stopped at 2020, because I'm sure you've heard of another respiratory illness that may have taken precedence in the last few years. So the COVID-19 also affected the resources for respiratory therapy and the services of Upstream to continue enrolling patients. However, when it was up and running and strong, really great data. If you see the number of hospital admissions avoided was 634. The bed days was 3,563. And in the end, we had they call it a soft savings or a facility cost avoidance, estimated at almost $3.5 million. So when we were up and running and full force, we were having very good outcomes with this. So when you implement any program, there's always barriers or challenges. So if we look at capacity, so when we first rolled these out in hospitals, we had to work with existing resources within our services. So we had to change around workload and things like that to try to implement this into our daily activities. EMP also did not have any increase in resources. So we were enrolling patients and adding follow-up to their workload. Again, COVID-19 happened the last 3 years, and then the limited pulmonary rehab. If we look at the action plans, inability to get action plans completed. So physician buy-in is variable across all the sites. And when patients do not go home with an action plan, they are more likely to return to hospital. And you saw that in the Inspired team, we do have physician champions. Some of them were able to help in getting more action plans signed, and then some weren't. Patients were reluctant to use their action plans in the beginning. So you have to remember they weren't used to self-management, and this is the whole goal of the program. And a lot of patients were used to having to go to the doctor and they tell them. So to be able to go to the pharmacy and get an antibiotic on your own, or start a steroid without having to see a physician first, was probably a little bit scary to them. And then you had the patients who overutilized their action plans. So they're renewed every year. And some patients would go, and within the first few months, they had used their prednisone and their antibiotics. Another barrier is the drug coverage. So Naida sees this a lot. Their work with social development, they're putting in pre-authorizations to try to get patients drugs. So they use the CTS guidelines, and patients that would benefit from medications recommended by these guidelines, but unfortunately, they're not all covered under the drug plans. And with the current systems, the drugs cannot be approved until the patient follows multiple steps, and this can take up to 3 to 9 months. And then we look at our reach. We're always trying to streamline our processes so that we can increase our reach and properly identify patients with COPD. And this is continuous, because with changes in electronic systems or changes in staffing, there's always re-education that needs to be performed. So then we can look at what's next. So expanding and reestablishing Inspired and Upstream. So expanding to areas that may not already be up and running, or reestablishing some of the sites, providing Upstream or even Inspired. I know here at the St. John Regional Hospital, we're just getting some staffing stability so that we can have our Inspired back up and running as it was before. We're always looking at ways of increasing access to screening spirometry for patients who do not yet have a diagnosis of COPD. And hopefully in 2024, we are going to have an electronic central database of spirometries to increase the accessibility of those. So currently every site stores their spirometries differently. Some results are available in the electronic record. I know Fredericton, I think theirs is available in their electronic record. But if you look at our site, we're all paper and nothing goes into the electronic record for the patient.
A couple of minutes, Jen.
Okay, so we're done. So
There's a question.
yeah, no, go ahead, questions.
Yeah, well, that's right. If I just held off, right, you would have been
Right?
done. One of the eligibility requirements for the program is to have a primary care provider. This is from an attendee. Many people in New Brunswick, as you know, do not have one. What would happen with those individuals who would benefit from the program but are unable to since they don't have a primary care provider?
If they're in hospital, then we'd have to get the hospitalist to cover them post-discharge.
Okay.
But for upstream, then we need someone to get the prescriptions from and change. And if they don't have a provider, then we could provide education, but we wouldn't be able to get action plans or optimize their medication.
Okay.
And again, that is one of the barriers, especially in New Brunswick with the amount of people who do not have family physicians or care providers.
So this is just a quick question for me. So the blue proffer you mentioned, I assume is Ventolin, right?
Yep.
Yeah, the rescue inhaler. So the CTS guidelines, of course, using the blue puffer, I think it has to be no greater than 3 times a week. So in an exacerbation, how often are they allowed to use the Ventolin?
We'd recommend 4 times a day, or 4 times a day until their symptoms resolve. Sometimes they'll write it, it's right in the action plan. It could be 7
Right.
days, 5 days until their symptoms improve. The 3 days a week is typically for like asthma. If they're using it more than 3 times a week, then that's a sign that their asthma is poorly controlled and needs to be optimized.
Yes. Yeah. I just wanted to see if it happened to apply here. Oh, there's a link or something. Who put that there? Oh, thanks, Dusty. So thank you very much, Jen and Naida. That was really great. That program's been around for a little while, and I remember working on the COPD strategy committee for New Brunswick quite a few years ago. So always good to hear that it's still working and working well. I think I'm going to just double check one more time. Oh, this is a big long one. You've mentioned patient overutilization. I had a patient ask me about this. They stated they had symptoms multiple times when they had to follow their action plan, a few times in a short period of time, and was told they overutilized it. So they weren't sure what to do since they had symptoms that would cause them to use their action plan often than they want to.
So when we talked about the odor, so some of the examples of those situations do happen. And then unfortunately, they would have to go back to their primary care physician or nurse practitioner time. Some patients were going in and filling their prescription right away as soon as they were discharged. So those were sometimes the examples of the overutilization that they just, again, didn't understand or needed more education, but they'd go in and they'd fill their prescriptions right away, right on discharge. So those were those examples, but you're right. There are going to be patients who do have more than 2 exacerbations a year.
And we're also going to have patients that are prescribed antibiotics from their doctor and only take it for 2 days until they feel better. So I think it's going to be a struggle on both sides, whether they take it too much or too little.